That nagging headache, a sore muscle after a tough workout, or, that persistent grinding ache of arthritis. We've all been there, haven't we?
Oh, absolutely.
Reaching for a common pain reliever, often without truly understanding the incredibly intricate dance happening behind the scenes in our bodies.
And that's precisely what we're going to change today. Welcome to the Deep Dive. We're embarking on an intensive, almost elite professional level exploration into the world of nonsteroidal anti-inflammatory drugs, what we commonly call NSAIDs,
Yeah.
and also the powerful yet complex therapies for conditions like hyperuricemia and gout.
Yeah, these aren't just everyday pills, are they?
No, not at all. They represent a fascinating and deep intersection of chemistry, physiology, and medicine. They offer immense relief, true, but they also demand a profound understanding of their precise mechanisms.
Our mission today, for you, our dedicated listener, is to truly master this information. We're going to unearth the most important nuggets of knowledge from detailed pharmacological sources.
Specifically, key excerpts from the highly respected Goodman and Gilman's The Pharmacology.
Exactly. We'll break down their intricate mechanisms of action, delve into their broad therapeutic uses, scrutinize their significant adverse effects, and even journey through the captivating historical origins of some of the most famous drugs in this class.
So by the end of this deep dive, you'll leave truly well-informed, understanding not just what these drugs do, but profoundly how and why.
Precisely. So let's unpack this complex world.
To truly grasp how NSAIDs work, we first need to understand the fundamental processes of inflammation, pain, and fever.
Right, the basics.
These are the very battlefields where these drugs exert their effects, and seeing them through the lens of a pharmacologist really helps us appreciate the precision of these medications.
So let's start with inflammation. It's often viewed as a negative, something we want to stop, but it's actually a vital part of our body's defense, isn't it?
Absolutely, it's essential for survival. Inflammation is your immune system's protective response to any injurious stimulus, whether it's noxious chemicals, infections, or physical injuries.
Okay.
Your body detects these threats and initiates a complex, rapid cascade to eliminate the cause and begin tissue repair.
But the problem arises when?
Well, the problem arises when this response becomes exaggerated or prolonged. That's when it leads to severe adverse consequences that can actually harm the body, like chronic pain or tissue damage.
And what are the telltale signs that this complex inflammatory response is underway? What are we looking for mechanistically?
Mechanistically, we see three primary hallmarks. First, there's a transient local vasodilation, meaning your blood vessels at the site of injury widen,
Okay.
and increased capillary permeability, where their walls become leakier. This allows fluids and crucial immune cells to more easily reach the affected area.
Makes sense.
Second, you see a significant infiltration of leukocytes and phagocytic cells. These are your body's frontline immune cells, rushing in to fight off pathogens or clear cellular debris. The cleanup crew, sort of.
Exactly. And third, there's eventually a process of resolution, which may or may not involve tissue degeneration and fibrosis, depending on the extent of the original damage.
So it's a very orchestrated response. What specific molecules are orchestrating all of this? I imagine it's a sophisticated chemical symphony.
That's a perfect way to describe it. It truly is a symphony of chemical signals. You have immediate mediators like histamine, bradykinin, and serotonin, or 5-HT.
Right.
These are quickly released and contribute to that initial vasodilation and early pain sensation. Then, critically, there are the lipid mediators derived from arachidonic acid, known as prostanoids and leukotrienes, or LTs.
Ah, the prostanoids, key for NSAID.
Absolutely key. Platelet activating factor, or PAF, also plays a role, as do a variety of cytokines like interleukin-1, IL-1, and tumor necrosis factor alpha, TNSA. The biosynthesis of prostanoids, in particular, significantly increases in inflamed tissue, making them prime targets for NSAIDs. Let's focus on the prostanoids for a moment, because that's where NSAIDs really come into play. Which specific prostanoids are key in mediating inflammation?
When it comes to inflammation, two prostanoids stand out as primary mediators. Prostaglandin E2, or PGE2.
PGE2? Okay.
Prostacyclin, PGI2. They powerfully increase local blood flow, enhance vascular permeability, and promote the infiltration of leukocytes by activating their specific receptors.
And there was another one you mentioned, PGD2.
Yes, prostaglandin D2, PGD2, primarily produced by mast cells. It contributes significantly to allergic inflammatory responses, especially in the lungs.
And how do these mediators ensure the right immune cells get to the inflammatory site? How does that recruitment work?
The process involves what we call endothelial activation. the inner lining of your blood vessels, the endothelium, becomes activated, leading to the expression of special adhesion molecules like selectins and integrins.
Like little molecular Velcro.
Exactly like molecular Velcro. They cause circulating white blood cells, the leukocytes, to slow down, roll along the vessel wall, and then firmly adhere before they migrate or infiltrate into the inflamed tissue.
Okay.
PGE2 and thromboxane A2, TXA2, specifically enhance this process of leukocyte chemotraction and endothelial adhesion, effectively drawing more cells to the fight.
And cytokines play a role here, too.
Oh, definitely. Cytokines, especially TNF and IL-1, are central orchestrators, controlling the entire inflammatory process. Many advanced anti-inflammatory therapies actually target these cytokine pathways directly.
Interesting.
Now, while cytokines themselves can induce the release of prostaglandins and TXA2, COX inhibitors, the drugs we're focusing on, primarily block the pyrogenic effects, the fever-inducing effects of these cytokines.
That brings us perfectly to pain. Inflammation clearly plays a big role in pain sensation, but how does that connection work at a cellular level? What are we actually sensing?
Pain sensation begins with specialized peripheral nerve endings called nociceptors.
Nociceptors, right.
These are the terminals of primary afferent fibers that act as sensory detectors for various noxious stimuli, be it intense heat, damaging acids, or excessive pressure. During tissue injury, non-neuronal cells, which are essentially the first responders in the injured tissue, release a complex cocktail of inflammatory mediators.
The chemical symphony again.
Exactly. This includes bradykinin, hydrogen ions, which indicate acidity, serotonin, 5-HT, ATP, neurotrophins like nerve growth factor, leukotrienes, and critically prostaglandins such as PGE2 and PGI2.
So what do these mediators do to the nociceptors? Do they just trigger them directly?
They do more than just trigger them. They actually reduce the threshold for nociceptor stimulation.
Ah, they make them more sensitive.
Precisely. They make these pain sensors more sensitive to stimuli that wouldn't normally cause pain, or they intensify the pain from already painful stimuli. This profound process is known as peripheral sensitization.
Like turning up the volume dial on the pain signal.
Perfect analogy. Turning up the volume right at the source. The analgesic activity of NSAIDs, particularly their peripheral component, is thought to largely represent the reversal of this very sensitization. By dampening the impact of these inflammatory mediators, NSAIDs essentially turn that volume back down.
That's a fascinating link. So NSAIDs are dialing down the peripheral pain signal, but is it just a peripheral effect, or do they act centrally too in the brain or spinal cord?
That's an excellent question, and it's where the understanding of pain gets even more sophisticated. NSAIDs certainly have important central actions, not just in the spinal cord, but also extending into the brain.
Okay.
We now know that both KOX1 and KOX2 enzymes are expressed in the spinal cord under normal conditions, and they actively release prostaglandins in response to peripheral pain stimuli.
So they're active centrally too?
Yes. And here's where it gets really interesting. Centrally active PGE2, and possibly PGD2, PGI2, and PGF2 contribute to what's called central sensitization.
Central sensitization. That sounds like the brain itself is becoming more sensitive to pain.
Precisely. It's an increase in the excitability of spinal dorsal horn neurons, leading to amplified pain perception, a phenomenon known as hyperalgesia.
Hyperalgesia, so normally painful things feel even worse.
Exactly. And it can also lead to allodynia, where non-painful stimuli are experienced as painful. Touch might feel like burning, for example.
Wow.
This reflects the plasticity of your nociceptive system, a kind of adaptive change invoked by injury. Typically, this central sensitization is reversible within hours to days, for example, in acute postoperative pain.
Okay.
However, in chronic inflammatory diseases, this system can undergo persistent modifications, leading to long-lasting changes in responsiveness that contribute significantly to chronic pain conditions.
So NSAID's central action helps dial down that central hypersensitivity too, a double whammy against pain.
Exactly, offering a dual approach to pain relief.
And finally, fever. How does the body generate a fever, and how do NSAIDs intervene to bring it down?
Your hypothalamus, a small but incredibly powerful region in your brain, acts as the body's central thermostat, meticulously regulating its temperature set point.
The thermostat, right?
In fever, this set point is deliberately elevated, usually as a protective response to infections, tissue damage, inflammation, organ graft rejection, or even malignancy.
So these things trigger the rise.
Yes, these conditions all enhance the formation of endogenous pyrogenic cytokines, which are fever-inducing messengers, such as IL-1, IL-6, TNFi, and interferons.
So the immune system signals the brain to turn up the heat, literally.
Exactly. This thermoregulatory response actually unfolds in two distinct phases. The initial phase might involve the release of ceramide in neurons of the preoptic area of the anterior hypothalamus.
Okay.
But the critical second phase, and the one most relevant to NSAIDs, is mediated by the coordinated induction of COX-2 and the subsequent rapid formation of prostaglandin E or PGE2.
PGE2 again? It's everywhere.
It really is central. PGE2 is unique because it can readily cross the blood-brain barrier and acts on specific receptors, primarily EPR3 and possibly EPR1, located on thermosensitive neurons within the hypothalamus.
And that interaction tells the hypothalamus.
It triggers the hypothalamus to elevate body temperature by promoting both an increase in heat generation through mechanisms like shivering and a decrease in heat loss, such as through peripheral vasoconstriction, making you feel cold while your temperature rises.
So if PGE2 is the key player in resetting that thermostat to a higher temperature, then NSAIDs essentially prevent that from happening.
That's precisely right. NSAIDs suppress this entire fever response by directly inhibiting the COX-2-dependent synthesis of PGE2.
Simple as that.
Well, molecularly simple, yes. By preventing the production of this key prostaglandin, they stop the upward adjustment of the body's temperature set point, thus bringing fever down. It's a very clear, direct, and effective mechanism for their antipyretic action.
Okay, that sets the stage beautifully. We've mastered the intricacies of inflammation, pain, and fever. Now, let's get to the very core of NSAIDs themselves. Their mechanism of action. What exactly are they doing at a molecular level? How do they perform this precise inhibition?
At their very core, NSAIDs exert their primary therapeutic effects by inhibiting the prostaglandin GH synthase enzymes, which are universally known as cyclooxygenases or QOXs.
QOX enzymes, got it.
And there are two main forms of these enzymes that are critically important for us to understand, POX1 and QOX2.
And I've heard that the distinction between QOX1 and QOX2 is absolutely crucial for how these drugs work, and especially for understanding their side effects.
This is absolutely crucial. The prevailing and well-supported understanding is that the inhibition of QOX2 largely mediates NSAID's desirable actions, their antipyretic, analgesic, and anti-inflammatory effects.
Because QOX2 ramps up during inflammation.
Yeah. Exactly. It's typically induced or ramped up, specifically during inflammation and other pathological states. However, the story doesn't end there. The vast majority of the adverse reactions associated with NSAIDs, unfortunately, are primarily caused by inhibiting both COMUF1 and cokinesis-2 in tissues where they perform essential ongoing physiological housekeeping functions.
Housekeeping functions, like what?
Think about vital processes in your GI tract, your kidneys, and your cardiovascular system. COX-A1 is essential there.
So if QOX2 is the crisis response enzyme, then QOX1 is more about daily maintenance, keeping things running smoothly.
That's an excellent analogy to keep in mind. QOX1 is constitutively expressed, meaning it's always present and active in those cells. It's the dominant source of prostanoids for vital housekeeping functions throughout your body. This includes maintaining proper hemostasis or blood clotting and ensuring gastric cytoprotection, which literally means cell protection, safeguarding the delicate lining of your stomach. COX2, on the other hand, is generally induced or significantly upregulated by inflammatory stimuli like cytokines, by mechanical shear stress on blood vessels, and even by tumor promoters. So it becomes a much more significant source of prostanoid formation, specifically in inflammation and potentially in cancer pathways.
But both contribute somewhat to normal function.
Yes, it's important to note that both enzymes do contribute to various autoregulatory and homeostatic prostanoid functions to some degree. It's not always a perfectly clean split.
So the problem with traditional NSAIDs, the non-selective ones, is that they're a bit like a blunt instrument, hitting both QOX1 and QOX2 indiscriminately. This explains why they have so many side effects, even when they're effective for pain.
Precisely. The indiscriminate inhibition of both inflammatory and homeostatic prostanoids mechanistically accounts for most of the adverse reactions we see. For instance, inhibiting QOX1 is largely responsible for the gastric adverse events and bleeding associated with NSAID use. QOX1 is the dominant cytoprotective isoform in your gastric epithelial cells, producing prostaglandins that protect the stomach.
Right, the stomach lining protection.
And it also forms TXA2 in platelets, which is a powerful activator of platelet aggregation and constricts blood vessels, crucial for clotting. So by blocking QOX1, you reduce that stomach protection and significantly increase bleeding risk.
And inhibiting QOX2 causes problems too.
Yes. QOX2-derived prostaglandins are vital in regulating blood pressure and normally act as endogenous inhibitors of hemostasis, preventing excessive clotting. Inhibiting COX-2, therefore, can cause or exacerbate hypertension and increase the likelihood of thrombotic events.
It's truly a delicate balance.
It really is a complex balance that these drugs disrupt.
This brings us to a truly unique drug, aspirin. How does its mechanism of action differ fundamentally from other NSAIDs?
That's a key distinction, and it's what sets aspirin apart. Aspirin is the only irreversible inhibitor of the COX enzymes that's in widespread clinical use.
Irreversible, that's the key word.
Absolutely. While most other NSAIDs bind to COX enzymes reversibly, meaning they attach and then detach aspirin, covalently acetylates the catalytic subunits of both COX-1 and COX-2 dimers. It forms a permanent chemical bond.
So it breaks the enzyme, basically.
It permanently modifies it.
Yeah.
So the duration of aspirin's effects isn't just about how long the drug is in your system. It's directly related to the turnover rate, or how quickly new COX enzymes are produced in different target tissues.
And that's particularly relevant for platelets, which are quite unique cells, right?
Exactly. Platelets are a nucleate. They lack a nucleus,
The nucleus.
which means they have a markedly limited capacity for synthesizing new proteins. Because of this, once aspirin inhibits platelet COX-1, that inhibition lasts for the entire lifetime of the platelet,
Which is how long?
about 8 to 12 days. Think about that. One tiny aspirin can essentially disable a platelet for its entire, roughly 2-week lifespan.
That's incredible precision.
It's an almost surgical level of precision, which is why it's so potent for heart health, but also why you can't just casually pop one before surgery. This means that even very low doses of aspirin, as little as 30 milligrams per day, lead to cumulative inhibition of platelet COX-1-dependent TXA2 formation over time.
So it builds up.
It does. Full recovery of platelet function only occurs after 8 to 12 days, once enough new, uninhibited platelets have been produced and released into circulation.
And this happens before it even gets fully absorbed.
Yes. This unique sensitivity of platelets to low-dose aspirin is also partly due to its pre-systemic inhibition in the portal circulation. It hits platelets even before it's fully absorbed into the main bloodstream and deacetylated to salicylic acid in the liver. Salicylic acid itself, importantly, has no acetylating capacity and is a much weaker, reversible COX inhibitor.
So aspirin permanently breaks the COX enzyme in platelets. What about acetaminophen or paracetamol? It's often grouped with NSAIDs, but its mechanism is quite distinct, isn't it?
It is indeed. Acetaminophen acts as a non-competitive reversible inhibitor, and it functions by reducing the peroxide site of the COX enzyme.
The peroxide site,
Yeah.
different target.
Yes. At typical therapeutic doses, it only partly inhibits COXs, meaning it doesn't shut them down completely. This partial inhibition explains its effectiveness as an antipyretic and analgesic, similar to aspirin, but also why it has only weak anti-inflammatory activity at those common doses.
Why is it weaker against inflammation?
It's less effective where inflammation is rampant because high concentrations of peroxides, which are typically found at inflammatory sites, actually reduce its COX inhibitory activity, making it less potent in those environments.
And what about the so-called COXIBs, or selective COX-2 inhibitors? If traditional NSAIDs are a bit like a blunt instrument hitting everything, the pharmaceutical world eventually came up with a more targeted approach, right? The COXIBs were supposed to be the refined solution to these broad side effects.
Precisely. That was indeed the brilliant rationale behind their development. Drugs like celecoxib and itocoxib emerged as this new subclass, specifically engineered to selectively inhibit COX-2 while sparing COX-1.
Sparing the housekeeping enzyme.
Exactly. It's worth noting that some older traditional NSAIDs like diclofenac and meloxicam also show a degree of COX-2 selectivity at their typical therapeutic doses.
How did they design them to be selective?
Their design is quite clever, relying on molecular geometry. They have a relatively bulky side group that fits nicely into a larger available side pocket present only in the COX-2 enzyme.
Ah, a bigger pocket in COX-2.
Right. This same bulky group is spatially hindered from entering the smaller binding channel of COX-1, allowing for their selective inhibition.
And getting into the molecular detail of aspirin's action again, how exactly does that acetylation happen? What's the specific binding site?
Aspirin specifically acetylates a particular serine residue, serine 529 in COX-1 and the homologous serine 516 in COX-2.
Serine 529 and 516, okay.
This covalent attachment of a bulky acetyl residue physically prevents arachidonic acid, the natural substrate, from binding to the enzyme's active site, thus blocking prostaglandin synthesis.
But there was something interesting about acetylated COX-2.
Yes, a fascinating molecular nuance. While acetylated COX-1 is simply inactivated, Acetylated COX-2 actually gets repurposed. It can then synthesize a different kind of molecule, 15-RHT,
15-RHT.
which can then be metabolized further into 15-epilipoxin A4, a compound with potential anti-inflammatory properties itself.
So aspirin isn't just a blunt instrument after all. There are subtleties.
Exactly. There are these subtle, almost ironic molecular outcomes.
So we've broken down how they work at a molecular level. Now let's talk about their general properties and how they move through the body. Their pharmacokinetics, commonly abbreviated as ADME, absorption, distribution, metabolism, and excretion.
Most NSAIDs, with the notable exceptions of aspirin and acetaminophen, are organic acids.
Organic acids. Okay.
This means they're generally well-absorbed orally, highly bound to plasma proteins, particularly albumin, and primarily excreted by either glomerular filtration or tubular secretion in the kidneys.
And they accumulate in inflamed areas.
Yes, a notable characteristic is their tendency to accumulate in sites of inflammation, where the local pH is typically lower. This can sometimes complicate the relationship between their plasma concentrations and how long the drug effect lasts directly at the target site.
Let's get into the specifics of their journey through the body, starting with absorption. How quickly do they get in?
NSAIDs are generally rapidly absorbed after oral ingestion, with peak plasma concentrations usually reached within 2 to 3 hours.
2 to 3 hours, okay.
However, the poor aqueous solubility of many NSAIDs can lead to less than proportional increases in drug exposure measured by AUC, or area under the curve, when the dose is increased, simply due to incomplete dissolution and absorption.
Does food affect this?
Yes. Food, and even commonly prescribed antacids, can delay their absorption, sometimes significantly. Some NSAIDs, like diclofenac and ibumetone, undergo substantial first-pass or pre-systemic elimination in the liver before reaching general circulation.
And aspirin hits the platelets early.
Yes, aspirin starts acetylating platelets within minutes of reaching the pre-systemic circulation in the portal system, which is crucial for its antiplatelet effect before it's metabolized.
Once absorbed, how are they distributed throughout the body? Do they go everywhere?
Most NSAIDs are extensively bound to plasma proteins, typically between 95% and 99%, primarily to albumin.
Very highly bound.
Extremely. This high protein binding is important because conditions that alter plasma protein concentration, like severe liver or kidney disease, can increase the free unbound drug fraction, potentially leading to increased effects or toxicities.
And displacement of other drugs.
Yes, highly protein-bound NSAIDs can also displace other drugs that compete for the same binding sites. They are widely distributed throughout the body and readily penetrate arthritic joints.
Into the joints themselves.
Yes, synovial fluid concentrations often reach about half of plasma concentrations for drugs like ibuprofen, naproxen, and piroxicam. Most also achieve sufficient concentrations in the central nervous system to provide a central analgesic effect, though to varying degrees. Celecoxib, being particularly lipophilic, moves readily into the CNS.
What about topical creams and gels? Do they work locally?
While topical formulations exist, direct transport into inflamed tissues through the skin is often minimal. Detectable concentrations in synovial fluid after topical use are primarily achieved via dermal absorption and systemic circulation. Newer targeted delivery methods, like nanoparticles, are actively being investigated to enhance more localized drug delivery.
And how are they eliminated from the body? How long do they stick around? The half-life.
The primary routes of metabolism and elimination for most NSAIDs are hepatic biotransformation, often involving cytochrome P450 isoforms like CYP-TC9, CYP1A2, and CYP334, followed by renal excretion.
Okay, liver, then kidneys.
The plasma half-life varies significantly. Ibuprofen, diclofenac, and acetaminophen have relatively short half-lives, typically 1 to 4 hours.
Short-acting.
Whereas piroxicam has a much longer half-life of about 50 hours in steady state. Naproxen's half-life is also comparatively long, but highly variable, ranging from 9 to 25 hours.
Big difference.
Huge difference. Elimination pathways frequently involve oxidation or hydroxylation, followed by glucuronidation or other conjugations, making the molecule more water-soluble for excretion.
And some can regenerate the active drug.
Yes, notably some glucuronide metabolites, particularly from propionic acid derivatives like naproxen and ketoprofen, can hydrolyze back into the active parent drug, potentially prolonging their elimination and effect.
Interesting loop.
Generally, NSAIDs are not recommended in advanced hepatic or renal disease due to potential adverse effects. And given their extensive plasma protein binding, most NSAIDs are not effectively removed by hemodialysis, with salicylic acid being a rare exception.
Are there individual genetic differences that affect how people process these drugs? This feels like a growing area of understanding.
Absolutely. Pharmacogenetics is very relevant here. The activity of the major metabolizing enzymes is influenced by a range of factors: genetic variation, age, sex, circadian rhythm, disease states, even smoking or drinking.
And drug interactions, too.
Definitely. Interacting drugs that are substrates, inhibitors, or inducers of these CYP enzymes play a significant role. For instance, genetic variations in CYP2C9 alleles that lead to decreased enzymatic function have been linked to elevated NSAID plasma concentrations, increasing the risk of adverse effects.
So some people might need lower doses.
Exactly. For individuals carrying these variants, dose reductions or choosing NSAIDs with shorter half-lives may be advisable. There's even emerging evidence that variations in your intestinal microbiota may contribute to variability in drug metabolism and elimination, though that's a more nascent area of research.
Now, what about acetaminophen's metabolism specifically, considering its well-known overdose toxicity? What's going on there at the molecular level?
That's a critical point to master. At therapeutic doses, only a small fraction of acetaminophen is oxidized into NAPQI and acetyl P-benzoquinonoimidone.
NAPQI, the toxic one.
Right. This is a highly reactive and toxic metabolite that is normally rapidly detoxified by a crucial compound in your liver called glutathione, or GSH.
Okay, glutathione handles it normally.
But following an overdose, the principal metabolic pathways, glucuronidation and sulfation, become saturated. This forces more of the drug down the CYP-mediated oxidation pathway, leading to the formation of significant hepatotoxic concentrations of NAPQI. That's the core of its overdose pathology.
So moving beyond the precise mechanisms and how they travel through the body, let's talk about that actual therapeutic uses. We know they help with pain and fever, but what else? What's the full scope?
The core actions of NSAIDs are indeed antipyretic, fever-reducing, analgesic, pain-relieving, and anti-inflammatory.
With the exception of?
The notable exception, as we've highlighted, is acetaminophen, which is primarily antipyretic and analgesic, but largely lacks significant anti-inflammatory activity at its typical therapeutic doses.
Starting with inflammation, how are they used in clinical practice for this?
NSAIDs provide mostly symptomatic relief from the pain and inflammation associated with a range of musculoskeletal disorders, like rheumatoid arthritis and osteoarthritis, greatly improving quality of life.
Arthritis, yeah.
Certain NSAIDs are also specifically approved for conditions like ankylosing spondylitis and gout. It's important to note that for patients with more debilitating inflammatory diseases, full therapeutic doses might not be sufficient on their own.
Need stronger stuff.
Exactly. More aggressive therapies, often with second-line agents like disease-modifying antirheumatic drugs, DMARDs, may be required in combination.
And for pain, how effective are they, especially compared to opioids, which are so often in the news?
NSAIDs are particularly effective against inflammatory pain of low to moderate intensity. While their maximal analgesic efficacy is generally less than that of opioids, they offer a crucial advantage.
Which is?
They lack the unwanted central nervous system adverse effects associated with opioids, like respiratory depression, sedation, and, importantly, the profound potential for physical dependence and addiction.
Huge advantage.
Massive. In fact, co-administration of NSAIDs with opioids can often reduce the opioid dose needed for adequate pain control, which helps mitigate opioid side effects.
Good combination sometimes, then.
Can be. Unlike opioids, NSAIDs don't alter the perception of sensory modalities other than pain. They're especially effective when inflammation has sensitized pain perception, making them ideal for postoperative pain or the chronic ache of arthritis.
But not all types of pain.
No. They generally don't relieve pain from hollow viscera, with one significant exception: menstrual pain.
Ah, menstrual cramps. Why that exception?
Because uterine cramps and other symptoms of primary dysmenorrhea are largely caused by the powerful release of prostaglandins from the endometrium during menstruation. By inhibiting prostaglandin synthesis, NSAIDs directly target the cause of the pain.
Makes sense. What else? Migraines.
Yes, they are also commonly used to treat migraine attacks and can be combined with other drugs like triptans or antiemetics. But generally, they lack efficacy in neuropathic pain originating from nerve damage itself.
What about their specific role in fever reduction?
NSAIDs effectively reduce fever in most situations where the body's temperature set point has been elevated due to infection or inflammation. However, they do not impact natural physiological temperature variations, like the circadian rhythm or temperature increases from exercise or a warm environment.
They just reset the thermostat when it's artificially high?
Exactly.
I remember hearing something about NSAIDs being used in newborns for a specific heart condition. Can you explain that, as it sounds almost contradictory?
Yes, that's a fascinating and critical application related to the fetal circulatory system, highlighting the precise and sometimes opposing roles of prostaglandins.
Opposing roles.
Yes, prostaglandins play a vital role in maintaining the patency or openness of the ductus arteriosus, a blood vessel connecting the aorta and pulmonary artery in the fetus. It normally closes shortly after birth.
Okay.
In cases where the ductus arteriosus remains inappropriately patent in neonates, leading to circulatory problems, drugs like indomethacin, ibuprofen, and other NSAIDs are used to close it.
They close it.
Yes. Conversely, in certain rare congenital heart diseases, where maintaining ductal patency is necessary as a bridge to definitive surgical repair, prostanoid analogs are actually infused to keep it open until surgery can be performed.
Wow, completely opposite effects depending on the need.
Precisely. It's a powerful application of their opposing effects on prostaglandin pathways.
That's a clear example. Now, a huge area of discussion for aspirin, and one that has evolved greatly, is its cardioprotective role. How exactly does that work, and is it truly unique to aspirin among the NSAIDs?
Aspirin's cardioprotective effect is indeed quite unique among NSAIDs due to its irreversible action. Its ingestion significantly prolongs bleeding time.
Because it hits the platelets permanently?
Exactly. It's attributed to its irreversible acetylation of platelet COX-1. This leads to the permanent suppression of platelet TXA2 formation and consequently inhibition of platelet function. This precise mechanism is thought to be the underlying basis for its profound cardioprotective benefits, preventing unwanted blood clots.
And what's the clinical impact of this for patients? Fewer heart attacks?
Clinically, aspirin has been unequivocally shown to reduce the risk of serious vascular events, like myocardial infarction or MI, by 20% to 25%. Very. And thrombotic strokes by about 10% to 15% in high-risk patients, such as those with a history of heart attack or stroke. Low-dose aspirin, typically 100 milligrams per day or less, is associated with a lower risk of gastrointestinal adverse events compared to higher doses.
But still some risk.
Oh, yes. Even low-dose aspirin can still cause a small, roughly twofold increase in serious GI bleeds and intracranial bleeds in placebo-controlled trials. But the benefits generally outweigh these risks in what we call secondary prevention of cardiovascular disease.
Secondary prevention, meaning after someone's already had an event.
Exactly. In patients who have already experienced a prior event.
But I've heard the picture is less clear for people who haven't had a prior event in primary prevention. Why the nuance there?
You're absolutely right. The issue is much more nuanced and has been debated extensively in primary prevention. That is, in patients who have never had a serious atherothrombotic event.
Why is it different?
Here, the numerical benefit of preventing myocardial infarction with aspirin can be finely balanced by the serious GI bleeds and intracranial hemorrhages it can precipitate. Recent large-scale randomized clinical trials for primary cardioprevention have struggled to consistently demonstrate a clear beneficial effect.
Why is that? Better treatments overall now.
That's part of it. Other cardioprotective treatments are now so widespread and effective, while the inherent GI bleeding risk with aspirin remains apparent. It highlights the critical importance of individualized risk-benefit assessment.
And what about other NSAIDs? Do they offer the same cardioprotection, ibuprofen, naproxen?
Generally, no. Most other NSAIDs, with their relatively short half-lives and reversible KOX inhibition, are not thought to provide cardioprotection. In fact, it's a critical drug-drug interaction.
They interfere.
Yes. Low-dose aspirin's cardioprotection can be lost when it's combined with other short-acting NSAIDs like ibuprofen or naproxen. This happens because these other NSAIDs can interfere with aspirin's access to its target site on platelet COX-1, physically blocking the irreversible acetylation.
So taking ibuprofen could cancel out your aspirin's benefit?
Potentially, yes. It undermines the effect. COX-2 selective NSAIDs, on the other hand, are inherently devoid of antiplatelet activity because mature platelets do not express COX-2. This is a very important distinction. Aspirin works on platelets in a unique way that most other NSAIDs do not replicate and can even interfere with.
Any other interesting clinical uses for NSAIDs beyond these major ones? We're trying to get that elite professional level of understanding.
Several, actually, and they further highlight the diverse roles of prostaglandins. In systemic mastocytosis, a rare condition with excessive mast cells, PGD2 mediates severe flushing, vasodilation, and hypotension.
Okay.
Aspirin or ketoprofen, used off-label, can be beneficial by inhibiting PGD2 synthesis. However, a caution. NSAIDs can also paradoxically cause mast cell degranulation in some individuals, so pre-blockade with antihistamines is often advised.
Interesting paradox.
Aspirin can also effectively inhibit the intense facial flushing induced by high doses of niacin, a cholesterol-lowering agent, which is also mediated by PGD2 release from the skin.
And in some rare kidney disorders.
Yes. In Bartter syndrome, a group of rare inherited kidney disorders. This condition involves increased PGK2 production due to renal COX2 induction. Indomethacin, combined with potassium repletion and spironolactone, significantly improves symptoms and biochemical abnormalities. Selective COX2 inhibitors have also been used.
And what about pregnancy complications, specifically preeclampsia?
Low-dose aspirin, specifically 81 or 100 milligrams, has shown effectiveness in reducing the incidence of preterm preeclampsia in at-risk women when administered early in pregnancy.
How does it help there?
It's thought to work by targeting platelet activation, endothelial inflammation, and renal dysregulation of blood pressure. Interestingly, studies suggest that evening dosing of aspirin may be more effective than morning dosing, possibly due to circadian rhythms and platelet activity. And finally, there's a growing and very significant area of interest in cancer chemoprevention.
I've heard about aspirin in colon cancer, but what's the detailed evidence?
Indeed. Compelling epidemiological studies suggest that daily aspirin use is associated with a statistically significant 24% decrease in the incidence and a 35% decrease in mortality from sporadic colorectal cancer.
Wow, that's substantial.
It is. Randomized controlled trials provide direct evidence for its beneficial effect in primary prevention of colorectal cancer in high-risk patients with Lynch syndrome, a hereditary condition. The evidence is weaker for familial adenomatous polyposis, or FAP, another hereditary cancer syndrome, but it remains an area of active research.
Did the COX2 inhibitors show promise there too?
They did. COX2 selective NSAIDs also showed efficacy in FAP, but were unfortunately withdrawn due to significant cardiovascular safety concerns, which we'll delve into shortly. It underscores the profound complexity of these drug benefits and risks.
Okay, so we've explored the extensive therapeutic benefits, which are clearly diverse and powerful, but now let's talk about the double-edged sword, the adverse effects of NSA therapy. I imagine the general rule, the one drilled into every clinician, is to use the lowest effective dose for the shortest feasible duration.
Absolutely. That's the paramount principle for minimizing adverse events and maximizing safety. It's also critical to remember that age is directly correlated with an increased probability of serious reactions.
So lower doses for older people.
Yes, lower starting doses are often warranted, sometimes even half the adult dose in elderly patients. And, as a major cautionary note that every professional must know, NSAIDs carry a black box warning related to their cardiovascular risk.
The cardiovascular risk, right.
And they're specifically contraindicated for perioperative pain following coronary artery bypass graft, or CABG, surgery due to a significant increase in the risk of myocardial infarction and stroke.
Let's start with the most common ones, gastrointestinal effects. What's actually happening in the gut?
The gastrointestinal system is indeed where NSAID side effects are most frequently observed, affecting around 40% of patients. Common symptoms include dyspepsia, indigestion, abdominal pain, anorexia, loss of appetite, nausea, and diarrhea.
But those symptoms don't tell the whole story.
No. It's crucial to understand that these symptomatic complaints are not reliably predictive of serious gastric or intestinal lesions, like subepithelial hemorrhages, erosions, or outright ulcers. These can be present in 30% to 50% of NSAID users and are often asymptomatic, healing spontaneously.
That's a chilling thought. You could be taking these for a minor ache and without any warning be developing serious internal damage. It really highlights why the lowest dose, shortest duration rule isn't just a suggestion, it's a lifeline. So someone could have severe bleeding or perforation without even knowing it.
Precisely. Serious complications like bleeding, perforation, a hole in the stomach or intestine wall, or obstruction occur at an annual rate of 1% to 2% in regular NSAID users, and many patients are entirely asymptomatic before such a life-threatening diagnosis is made.
Are there factors that increase the risk?
Yes. Certain factors significantly increase this risk, including active Helicobacter pylori infection, heavy alcohol consumption, and the concurrent use of glucocorticoids, which are powerful anti-inflammatory steroids.
What are the detailed mechanisms behind this GI damage? It sounds like it's more than just a simple irritation.
It's multifactorial and quite complex. The primary mechanism is the systemic inhibition of COX1 in gastric and intestinal epithelial cells.
Inhibiting the housekeeping enzyme again.
Right. This depresses the formation of crucial mucosal cytoprotective prostaglandins like PGI2 and PG2. These eicosanoids normally perform vital protective functions. They inhibit acid secretion, enhance mucosal blood flow, and promote mucus and bicarbonate secretion, forming a protective barrier.
Does KOX2 play a role here too?
Yes. COX2 also contributes to constitutive prostaglandin formation in gastric epithelium and may play a role in ulcer healing, so its inhibition can also be detrimental.
Is there also direct irritation?
Yes, beyond systemic effects, there's also a transient contribution from local irritation. Orally administered NSAIDs, being organic acids, can directly interact with the mucosal phospholipid bilayer, compromising its hydrophobic lining. However, this direct irritation is less impactful than systemic effects.
How do we know that?
Well, it's evidenced by the limited reduction in serious GI events with enteric-coated formulations, which are designed to bypass the stomach. NSAIDs can also cause mitochondrial and endoplasmic reticulum damage directly within epithelial cells.
And the effect on platelets adds to the risk.
Absolutely. The inhibition of platelet function by NSAIDs significantly increases the likelihood of bleeds once mucosal damage has occurred, turning a small lesion into a serious hemorrhage. Lastly, emerging research suggests NSAIDs can alter the gut microbiota, impacting their disposition, efficacy, and toxicity, and contributing to NSAID-induced enteropathy.
Given these profound risks, what strategies are actually used to mitigate GI adverse effects in patients who need NSAIDs?
Co-administration of proton pump inhibitors, or PPIs, or H2 antagonists is a very common strategy, as it effectively reduces the rate of duodenal and gastric ulceration.
PPIs like omeprazole.
Exactly. However, PPIs, which are also metabolized by CYP2C9 and can interact with NSAIDs, may paradoxically increase the risk of damage in the small intestine, potentially by inducing dysbiosis and imbalance in gut bacteria.
So fixing one part might hurt another.
Potentially. Researchers are actively exploring other approaches, such as poorly absorbable antibiotics, mucosal protective agents, or probiotic supplementation. The COX2 selective inhibitors were, of course, designed with GI safety in mind, and they are indeed less prone to induce gastric ulcers compared to equally efficacious doses of non-selective NSAIDs, although this advantage can be lost with very high doses or in high-risk patients.
Now let's turn to the cardiovascular effects, which have been a major point of concern for NSAIDs, particularly the KOX2 inhibitors. It sounds like a classic case of fix one problem, create another, doesn't it? When they designed these KOX2 inhibitors to be gentler on the stomach, they inadvertently stirred up a cardiovascular hornet's nest. Can you walk us through that balance?
That's precisely it. It's a very stark example of the delicate balance in pharmacology. KOX2 selective NSAIDs were developed to improve GI safety by sparing COX-1. However, by selectively inhibiting KOX2, they depress the formation of PGI2, prostacyclin.
PGI2, the good prostaglandin.
Well, it's a powerful vasodilator and inhibitor of platelet aggregation. It normally counteracts prothrombotic stimuli. Crucially, these selective inhibitors do not inhibit the COX-1 catalyzed formation of platelet TXA2, which is highly prothrombotic.
So you lose the anti-clotting PGI2 but keep the pro-clotting TXA2.
Exactly. This creates an imbalance, shifting the cardiovascular environment towards a prothrombotic state. Additionally, renal PGI2 and PGE2, formed by KOX2, play roles in blood pressure homeostasis. Their inhibition can lead to increased blood pressure, further adding to cardiovascular risk.
So clinical trials definitively showed this increased risk. Vioxx, for example.
Yes, randomized clinical trials involving celecoxib and the now withdrawn valdecoxib and rofecoxib, Vioxx, revealed approximately a 1.4-fold increase in the incidence of serious cardiovascular events, myocardial infarction, stroke, and vascular death.
And this isn't just the coxibs.
No, this elevated risk extends to diclofenac, which exhibits similar KOX2 selectivity, and some other older non-selective NSAIDs when used at high doses.
Is there any NSAID that might be an exception to this cardiovascular risk that could actually be safer? Naproxen.
There's a nuance that's been debated for naproxen. While the data is complex, some individuals may experience a sustained antiplatelet effect with naproxen due to considerable variation in its half-life.
So it might inhibit KOX-1 enough in some people.
Possibly, allowing for some platelet inhibition. However, identifying these individuals isn't clinically practical, so it cannot be universally recommended as a safer option. The FDA's official stance reflects this, issuing a cardiovascular risk warning on all NSAIDs and stating insufficient data to definitively distinguish risk between them.
What about heart failure? Can NSAIDs actually make heart failure worse?
They absolutely can. NSAIDs significantly increase the risk of heart failure and can exacerbate pre-existing heart failure, especially at high doses. This is thought to occur through several mechanisms, primarily fluid retention and blood pressure increases, which are direct consequences of their renal effects. There are also potentially direct effects on the myocardium and vasculature. A specific black box warning also contraindicates their use for perioperative pain in CABG surgery due to these grave risks.
So how do clinicians try to minimize this profound cardiovascular risk when these drugs are still so widely used?
The key remains prescribing the lowest possible dose for the shortest possible period. This approach considers factors like the specific dose, the drug's half-life, its degree of COX-2 selectivity, its potency, and the overall duration of treatment. It's about carefully balancing the need for relief against these significant hazards.
Let's delve into renal and blood pressure effects next. How do NSAIDs specifically impact the kidneys and blood pressure?
All NSAIDs are associated with renal and renovascular adverse events, including potential acute kidney injury and even chronic renal failure.
How common is hypertension?
We can expect up to 5% of regular NSAID users to develop new-onset hypertension or worsen existing hypertension. Interestingly, hypertensive complications might occur more commonly with COX-2 selective agents than with non-selective NSAIDs. Overall, the risk of heart failure is roughly doubled with NSAID use.
But I thought they usually didn't affect healthy kidneys significantly. Where does this risk arise?
You're correct. In healthy individuals, NSAIDs generally have minimal effect due to robust regulatory system redundancy. However, the picture changes dramatically in situations that stress these systems.
Like what kind of situations?
Conditions like dehydration, hypovolemia from diuretic use, congestive heart failure, hepatic cirrhosis with ascites, or pre-existing chronic kidney disease. Essentially, any state where the sympathoadrenal or renin-angiotensin systems are activated increases reliance on renal prostaglandin formation.
So in those vulnerable patients, prostaglandins become critical.
Exactly. Prostaglandin formation becomes crucial for maintaining kidney perfusion and regulating blood pressure, and NSAID inhibition becomes highly detrimental.
So in vulnerable patients, NSAIDs can cause serious renal problems. What are the specific mechanisms?
Precisely. NSAIDs impair the prostaglandin-induced inhibition of chloride reabsorption and the action of antidiuretic hormone in the kidneys. This directly leads to salt and water retention and consequently edema.
And blood pressure effects.
The inhibition of COX-2-derived prostaglandins, which regulate renal medullary blood flow and promote sodium excretion, can lead to a rise in blood pressure, further increasing cardiovascular risk.
What about potassium levels? Hypokalemia?
Yes, NSAIDs also promote potassium reabsorption due to decreased sodium availability and suppressed prostaglandin-induced renin secretion. This can lead to hyperkalemia, dangerously elevated potassium, particularly when combined with other drugs that also elevate potassium like ACE inhibitors or potassium-sparing diuretics.
What types of renal failure can NSAIDs cause?
Several forms. First, acute kidney injury, AKI, often reversible. This occurs when inhibiting vasodilator prostaglandins depresses renal blood flow, leading to ischemic episodes and acute tubular necrosis.
How does that present?
Typically an acute increase in plasma creatinine without major proteinuria. It's a particular risk in older individuals and dehydrated athletes. If recognized early and NSAIDs are stopped, function often recovers.
Okay, what else?
Second, a more subacute form is acute interstitial nephritis, an inflammatory reaction often triggered by NSAID-induced immune mechanisms. Finally, there's analgesic nephropathy, a slowly progressive renal failure with papillary necrosis, now rare since phenacetin was withdrawn.
Moving on to hypersensitivity reactions. How common are these with NSAIDs, and are they true allergies?
They are among the most frequent hypersensitivity drug reactions. They can occur in 10% to 25% of patients with pre-existing asthma, nasal polyps, or chronic urticaria, and about 1% of healthy individuals. Even low doses of aspirin can provoke reactions.
Are these true allergic reactions or something else entirely?
Most are pseudo-allergic reactions, not IG-mediated in the classic sense, though they mimic allergic symptoms.
What's the mechanism then?
It's thought to involve inhibition of PGE2 formation. This diverts eicosanoid precursors towards the 5-lipoxygenase pathway, leading to increased formation of potent cysteine leukotrienes.
And these leukotrienes cause?
They activate mast cells and eosinophils, underlying phenotypes like NSAID-exacerbated respiratory disease, NARD, vasomotor rhinitis, bronchial constriction, angioedema, urticaria, common in predisposed asthma patients, or NSAID-exacerbated cutaneous disease, urticaria, and angioedema.
So if someone has a pseudo-allergic reaction to one NSAID, does that mean they can't take any other NSAID? Is there cross-sensitivity?
Yes, this is critical. Pseudo-allergic hypersensitivity is considered a contraindication to therapy with any other NSAID due to the very high probability of cross-sensitivity. It's a class effect.
But true allergies exist too.
Yes. True allergic hypersensitivity reactions, IgE or T-cell mediated, are induced by specific immunologic mechanisms and are generally more restricted to individual NSAIDs or chemically similar ones. These can present with cutaneous and respiratory symptoms, hypotension, even anaphylaxis. Treatment is similar for both types, involving support and epinephrine for severe cases.
Let's briefly touch on aspirin resistance. Is that a common phenomenon, meaning aspirin just doesn't work for some people?
Aspirin resistance is a collective term for any treatment failure. However, true pharmacological resistance, where the drug fails to inhibit COX, is actually rare.
So what's usually going on?
More commonly, it's pseudoresistance. This reflects issues like delayed and reduced drug absorption, particularly with enteric-coated aspirin formulations, complicating administration and efficacy, often a pharmacokinetic issue, not pharmacodynamic.
Now, a very serious adverse effect for some NSAIDs is hepatotoxicity or liver damage. Let's start with acetaminophen, which is infamous for this in overdose.
Acetaminophen overdose is indeed the most serious acute adverse effect, leading to potentially fatal hepatic necrosis. Sadly, about two-thirds are intentional. They account for significant ED visits and hospitalizations.
How does that happen at a molecular level? Remind us of the mechanism of liver damage.
At therapeutic doses, only a small portion is oxidized to NAPQI, the toxic metabolite, normally detoxified by glutathione, GSH. In an overdose, glucuronidation and sulfation pathways saturate,
Forcing more down the NAPQI path.
exactly, leading to significant NAPQI formation. This reactive NAPQI depletes hepatic GSH and covalently binds to cellular macromolecules, causing widespread dysfunction, oxidative stress, and cell death. Renal tubular necrosis and hypoglycemic coma can also occur.
What kind of doses are we talking about?
Liver injury typically occurs after 10 to 15 grams in adults or 150 millikilograms in children. Doses of 20 to 25 grams can be fatal. Transaminases elevate 12-36 hours post-ingestion, with clinical signs manifesting within 2-4 days.
Are there any factors that increase susceptibility to acetaminophen-induced liver damage even at therapeutic doses?
Yes. Conditions that induce CYP enzymes, like chronic heavy alcohol consumption, or those that deplete GSH, like fasting or malnutrition, increase susceptibility, even at therapeutic doses, though this is uncommon. In non-fatal cases, the hepatic lesions are generally reversible.
And what about other NSAIDs and hepatotoxicity? Is liver damage a common risk across the class?
While the overall NSAID class has a low rate, less than 1 per 100,000 diclofenac and lumiracoxib have a higher reported rate, about 6 to 11 per 100,000 users annually.
Why diclofenac?
Hepatotoxicity may involve hypersensitivity and metabolic aberrations. One metabolite, 4-ohydroxydiclofenac, can form reactive benzoquinonenes, similar to NAPQI depleting GSH. Also, formation of diclofenac acyl glucuronide via UGT2B7 is implicated, with genetic variations linked to increased risk. Generally, NSAIDs aren't recommended in advanced hepatic disease.
Let's discuss Reye syndrome, which is a major reason aspirin is largely avoided in children and young adults now.
Indeed. Due to a strong epidemiological association established decades ago, aspirin and other salicylates are strictly contraindicated in children and young adults under 20 with viral illness-associated fever, like flu or chickenpox.
What is Reye syndrome?
It's a severe, often fatal disease characterized by acute onset of encephalopathy, brain dysfunction, and liver dysfunction, with fatty infiltration of the liver and other viscera. While the exact mechanism linking aspirin is unclear, the evidence is compelling.
So it's rare now?
Yes. The incidence has dramatically declined with decreased aspirin use in children. Acetaminophen and ibuprofen have not been implicated and are the agents of choice for fever in children and youth.
Finally, a quick note on vaccination and NSAIDs. Is it okay to take them before or after a vaccine to reduce symptoms, or is there a concern about interfering with the immune response?
NSAIDs are indeed often taken to prevent or treat vaccine reactions like pain or fever. However, there's been some contrasting data regarding potential interference with the desired vaccine-induced immune response, specifically antibody production.
So what's the recommendation?
Because of this lack of clear evidence that prophylactic use doesn't dampen the response, the World Health Organization currently advises against prophylactic use of NSAIDs at the time of vaccination. Use them if symptoms arise, but not preemptively.
So NSAIDs are clearly potent, with many valuable uses, but also a significant list of profound adverse effects. Now, let's navigate the complexities of how they interact with other medications. This is crucial for safe prescribing and use, and for you to truly master this topic.
Absolutely. One of the most critical interactions involves concomitant use of NSAIDs and low-dose aspirin for cardioprotection. Studies clearly show this combination significantly increases the likelihood of GI adverse events, a double whammy for GI risk.
And it also interferes with aspirin's protective effect, doesn't it? This idea of one drug blocking another's beneficial action.
Precisely. This is very important. Prior occupancy of platelet GOX1 by another NSAA, like ibuprofen or naproxen, can physically impede aspirin's access to its acetylation target, Cervitoid 29.
Blocking the permanent binding site.
Exactly. This prevents the irreversible inhibition crucial for aspirin's cardioprotective effect. It effectively undermines why many patients take low-dose aspirin. Celecoxib is less likely to cause this specific interaction in vivo, but carries its own direct cardiovascular hazard. So pain management in patients with cardiovascular disease remains a significant challenge.
What about interactions with ACE inhibitors, commonly used for blood pressure and heart conditions?
And NSAIDs can attenuate, weaken the effectiveness of ACE inhibitors by blocking production of vasodilator and natriuretic prostaglandins.
Working against the ACE inhibitor.
Yes. Furthermore, the combination can lead to marked hyperkalemia, dangerously elevated potassium, especially high risk in the elderly and those with hypertension, diabetes, or ischemic heart disease.
And what other drugs, like corticosteroids or SSRIs, might increase GI risk when combined with NSAIDs?
Yes, both corticosteroids and SSRIs, selective serotonin reuptake inhibitors, can significantly increase the frequency or severity of GI complications when combined with NSAIDs due to additive risks or effects on platelet function.
What about blood thinners like warfarin? That sounds like a particularly dangerous combination.
This is a major concern. NSAIDs significantly augment bleeding risk with warfarin. Almost all NSAIDs temporarily suppress platelet function. Additionally, some NSAIDs increase warfarin levels by interfering with its metabolism.
So avoid combining them.
Concurrent administration should generally be avoided due to the heightened bleeding risk.
I recall you mentioned earlier that highly protein-bound NSAIDs can displace other drugs from their binding sites. Can you elaborate on the implications of that?
Yes. Many NSAIDs are highly protein-bound, so they can compete for and displace other highly bound drugs from albumin.
Like which ones?
Drugs like warfarin, sulfonylurea, hypoglycemic agents for diabetes, or methotrexate. When the NSAID displaces these, more free, active drug becomes available, potentially leading to toxicity. Dosage adjustments may be needed. Lithium is another key one. NSAIDs reduce its renal excretion, risking toxicity.
Any other notable, perhaps surprising interactions?
A few. Probenecid can block penicillin transport from CSF and decrease its renal secretion, prolonging its levels, a therapeutically exploited interaction. Conversely, magnesium aluminum antacids can alkalinize urine, increasing salicylic acid clearance. Stopping the antacid can then cause salicylate levels to rise dangerously. And salicylate competes with thyroid hormones, penicillin, phenytoin, bilirubin, uric acid, and other NSAIDs for protein binding sites. Aspirin also acetylates albumin itself, potentially altering other drug binding.
Okay, we've laid a truly strong foundation. Now let's zoom in on specific properties of individual NSAIDs, starting with the salicylates, particularly aspirin, with its profound history.
Aspirin, acetylsalicylic acid, the acetate ester of salicylic acid.
Yeah.
Hugely consumed globally for cardioprotection and pain, fever, inflammation relief. But its potential for misuse and serious toxicity is often profoundly underappreciated. Still a cause of fatal poisoning, especially in children.
It has a truly fascinating history dating back centuries, from willow bark to Hoffman's acetylation.
Indeed. Willow bark use documented by Hippocrates, clearly by Edmund Stone, in 1763 for fevers. Aspirin comes from meadowsweet, Spirea ulmaria, another source. Salicin crystallized 1829, salicylic acid synthesized 1859, widely used by 1874 for rheumatic fever, gout fever, but tasted awful, and caused severe GI effects.
Which led to?
Felix Hoffmann at Bayer in 1899, seeking something better for his father's arthritis, revisited earlier work acetylating salicylic acid. Bayer began marketing aspirin in 1899, improving tolerability and ushering in a new era.
You mentioned aspirin's irreversible COX inhibition. How does that translate to its ADME, particularly its unique dose-dependent elimination, which just sounds like a critical detail for clinicians?
This is truly crucial. Aspirin is rapidly absorbed orally, upper small intestine, peak plasma in 1 hour, absorption influenced by tablet disintegration, stomach pH, gastric emptying, Rectal absorption, slower, inconsistent. Skin absorption, methyl salicylate, possible. Enteric coating delays reduces bioavailability by roughly half, a likely cause of pseudoresistance.
And metabolism.
Rapidly deacetylated to salicylic acid, its main active metabolite. Salicylic acid is widely distributed, crosses placenta, 80–90% protein bound, decreases as concentration rises. Aspirin acetylates albumin 2. Excretion via urine is variable, pH dependent. Now the critical detail, nonlinear pharmacokinetics. Salicylate half-life is 2–3 hours at low antiplatelet doses, rises to 12 hours at anti-inflammatory doses, and 15–30 hours at toxic doses.
Why such a big jump?
Because the liver's capacity to metabolize salicylate, forming salicylic acid phenolglucuronide, is limited and saturates at higher concentrations. Small dose increments at high levels can disproportionately increase plasma levels, risking severe toxicity. Monitoring plasma salicylate is useful. Optimal anti-inflammatory is 150, 300, 300 g/ml, risks adverse effects.
What are the main therapeutic uses for aspirin now, given its long history and the rise of other NSAIDs?
Systemic analgesic antipyretic. Adults, 325 of 1,000 milligram, Q4 6 hours. Rarely used for chronic inflammatory diseases now, others preferred for GI safety profile, though sometimes weakly supported. Anti-inflammatory for acute rheumatic fever, 4–8 g/day, max 4-day general use. Rectal for infants, suppresses acute rheumatic fever. Other salicylates. Diflunisal, not converted to salicylic acid. Competitive COX inhibitor, potent anti-inflammatory analgesic, 3–4x aspirin for OA strains. Minimal antipyretic, poor CNS penetration. Fewer auditory, GI, antiplatelet effects. Mesalamine 5-ASA, local effect in inflammatory bowel disease, IBD. Oral forms delivered to lower intestine, pH coatings, bacterial cleavage, also rectal. Derivatives like sulfasalazine, olsalazine, balsalazide for IBD, some for RAAS. Methyl salicylate, oil of wintergreen, topical, but can cause systemic toxicity from skin absorption, reported interaction with warfarin.
Let's delve into aspirin's adverse effects and toxicity in more detail, starting with its significant impact on respiration.
It is profound. Salicylates increase O2 consumption, CO2 production, uncoupling oxidative phosphorylation, stimulating respiration directly, medulla, and indirectly, CO2. Leads to increased rate depth, fall in peak O2, initial respiratory alkalosis.
An acid-base balance.
Body compensates for alkalosis by increasing renal bicarbonate excretion with NAP plus K+, lowering plasma bicarbonate. Severe cases children often present with mixed respiratory metabolic acidosis. Toxic doses impair renal function, cause saltwater retention.
And cardiovascular effects beyond the cardioprotective aspect of low-dose aspirin.
Low dose lowers CV risk. High therapeutic doses can increase plasma volume, decrease hematocrit, cause vasodilation, increase cardiac outwork, risk of heart failure, pulmonary edema in compromised patients. High doses can cause non-cardiogenic pulmonary edema, elderly.
What about the GI effects that famously led Hofmann to improve it? How bad can they be?
Epigastric distress, heartburn, nausea, vomiting common. More seriously, erosive gastropathies, ulcers, hemorrhage. Bleeding, often painless, insidious, can lead to iron deficiency anemia, 3–8 milliliter fecal blood loss in anti-inflammatory doses. Ulcerous lesions often seen on gastroscopy, even if asymptomatic.
And hepatotoxicity?
Hepatic injury possible, usually high doses, 150 g/ml plasma salicylate, often after months, especially in connective tissue disease, GRA. Often asymptomatic, raised transaminases, reversible on withdrawal. Contraindicated in chronic liver disease, large doses. Hyperglycemia, glycosuria, glycogen depletion.
You mentioned its effects on uric acid excretion earlier with dose-dependent effects. Can you elaborate on the specifics there?
Highly dose-dependent. Low doses, 1–2 g/day, decrease urate excretion, elevate plasma urate. Intermediate, 2–3 day, no net effect. High doses, 5 g/day, poorly tolerated, induce uricasuria, lower plasma urate. Critically, even small doses block effects of other uricosurics like probenecid.
How does it affect blood, beyond the antiplatelet effect?
Irreversible platelet inhibition is key for cardioprotection. Stop 1 week before elective surgery if possible, exceptions for high-risk CV surgery. Avoid in severe hepatic damage, hyperprothrombinemia, VIT-K deficiency, hemophilia, rare mild hemolysis in G6PD deficiency.
And endocrine or ototoxic effects. What should listeners be aware of?
Long-term use can decrease thyroidal iodine uptake clearance, increase T4, T3 disappearance, competitive displacement from binding proteins, ototoxic effects, hearing impairment, tinnitus, common at high doses, sometimes low, resolve on withdrawal, likely direct salicylic acid effect.
What about pregnancy and local effects?
Long-term use linked to reduced birth weights, increased perinatal mortality, third trimester use, anemia, hemorrhage, prolonged gestation delivery, avoid. Premature ductus arteriosus closure risk, Locally, salicylic acid irritates skin mucosa, destroys epithelial cells, uses keratolytic.
And the most serious scenario, salicylate intoxication or poisoning. What are the key clinical manifestations and how quickly do they arise?
Severe medical emergency, often fatal in children. CNS, initial stimulation, agitation, convulsions, then depression, confusion, dizziness, tinnitus, deafness, delirium, psychosis, stupor, coma, intense hyperpnea, hyperpyrexia, high fever due to uncoupling oxidative phosphorylation, lethal dose variable 10-30 gram aspirin adults, methyl salicylate, highly toxic, 4-millipal, severe in child, mild chronic intoxication, salicilism, headache, dizziness, tinnitus, vision changes, confusion, drowsiness, sweating, thirst, hyperventilation, GI.
How does the toxicity affect respiration and acid-base balance specifically, given that patients often present with complex acid-base disorders?
Respiratory effects cause severe acid-base disturbances. Direct medullary stimulation plus indirect CO2 from uncoupling. Hyperpnea, uncoupling hyperthermia. Prolonged high doses medullary depression, central respiratory depression, circulatory collapse, respiratory acidosis. Respiratory failure, usual cause of death. Elderly with chronic intoxication, non-cardiogenic pulmonary edema, indication for dialysis. Acid base, high therapeutic doses, initial respiratory alkalosis plus compensatory metabolic acidosis. Children with toxicity usually present with mixed respiratory metabolic acidosis, low pH, low bicarbonate. Direct respiratory depression prevents adequate CO2 hyperventilation, metabolic acidosis from salicylate displacing bicarbonate, impaired renal function, sulfuric phosphoric acid, decreased aerobic metabolism, pyruvic, lactic, acetoacetic acids.
And how does it affect water and electrolytes, which are crucial for organ function?
Low PSO2, decreased renal bicarbonate reabsorption, increased Ni plus, K plus, quadric excretion, water loss from sweating, hyperventilation, profound dehydration, all these poor children, often hypernatremia, cardiovascular, toxic doses exaggerate high-dose responses, central vasomotor paralysis, petechiae, pinpoint hemorrhages, from defective platelet function, metabolic large doses meter, hypoglycemia, glycosuria, glycogen depletion, epinephrine release. Reduce aerobic glucose metabolism, increase G6 pace, promote glucocorticoid secretion, hypoglycemia, brain injury risk in children, negative nitrogen balance, aminoaciduria, reduce lipogenesis, inhibit lipolysis, displace fatty acids, increase fatty acid oxidation, decrease plasma-free fatty acids, phospholipid cholesterol, increased ketone body oxidation.
How is such a severe salicylate overdose managed? This is a medical emergency.
Acute medical emergency, no specific antidote. Aggressive supportive care, key. Canes. Sodium bicarbonate for urine alkalinization increases salicylate excretion. Hemodialysis, highly effective for removal, indicated severe cases. High levels, altered mental status, pulmonary edema, refractory acidosis. Activated charcoal if within 4 hours for acetaminophen overdose. N-acetylcysteine, NAC, is the antidote. For salicylically monitor glucose, hypoglycemia. Supportive care for hepatic renal failure. Liver transplant, last resort.
That was an incredibly detailed look at aspirin. Now let's quickly touch on acetaminophen again, its unique properties, especially regarding its well-known overdose toxicity since it's so commonly available.
Acetaminophen, paracetamol, active metabolite of phenacetin, household name, raises pain threshold, analgesic. Widely available OTC, but beware. Present in many fixed-dose combinations, risk of unintentional overdose. Mechanism, non-selective COX inhibition at peroxide site. Weak anti-inflammatory at common doses with 1,000 milligrams per day because high peroxide levels at inflammation sites reduces activity.
And its ADME specifics for acetaminophen.
Excellent oral bioavailability, peak 30-60 minutes, T12 2 hours. Uniformly distributed, less plasma protein binding than NSAIDs. Primarily hepatic conjugation, glucuronic acid 60%, sulfuric acid 35%. Small portion N-hydroxylated to NAPQI, toxic. Normally detoxified by glutathione, GSH. Children have less glucuronidation capacity.
What makes it so valuable then if it has such a serious overdose risk? Why is it still so popular?
Valuable when aspirin SI is contraindicated. Hypersensitivity, ray risk, bleeding disorders. Dose 325, 650 milligram Q4 6 hours. Max 4 GDA adults, 2 GDA heavy alcohol users. PAIDs, 10-15 millibeing disorders. Injectable for opioid sparing. High tolerability at therapeutic doses. No relevant CV, respiratory, platelet coagulation effects. Less GI issues than NSAIDs at 1 day.
But the overdose mechanism is what everyone, from a layperson to an elite professional, needs to understand. Can you re-emphasize the molecular basis of the toxicity?
Critically, most serious acute effect, potentially fatal hepatic necrosis, Occurs because glucuronidase sulfate pathway saturate in overdose. Increases NAPQI formation via CYP pathway. Toxic NAPQI depletes hepatic GSH, binds covalently to cell macromolecules, dysfunction, oxidative stress, cell death, apoptosis, necrosis, renal tubular necrosis, hypoglycemic coma can occur. Toxic doses. 10-15 gene adults, 150 milligram children cause hepatotoxicity, 20-25 gene potentially fatal. Susceptibility increased by CYP induction, alcohol, or GSH depletion, fasting malnutrition.
So symptoms can be misleading at first, delaying recognition of the danger.
Yes, very much so. First 1-2 days. Just nonspecific gastric distress, nausea, abdominal pain, anorexia belies seriousness, clinical hepatic damage within 2 to 4 days, right subcausal pain, tender hepatomegaly, jaundice, coagulopathy, liver enzymes peak 72-96 hour, maybe hepatic encephalopathy, reversible in non-fatal cases.
And for management, what's the cornerstone of treatment for acetaminophen overdose?
Activated charcoal with infrared reduces absorption. Cornerstone and specific antidote, N-acetylcysteine, NAC, indicated for risk of hepatic injury. Detoxifies NAPQI, repletes GSH, conjugates directly. Given within 8-16 hours, mortality plummets to 1%. Aggressive supportive care. Hepatic renal failure. Monitor glucose. Liver transplant for fulminant hepatic failure.
Let's move to the acetic acid derivatives, a diverse group including diclofenac and indomethacin, often prescribed for more intense pain and inflammation.
Diclofenac, phenylacetic acid derivative, Europe's most used NSAID. Highly potent. Considerable COX-2 selectivity, similar to celecoxib. Rapid absorption, extensive protein binding, short T12, 1-2 arity, accumulates in synovial fluid, longer effect in joints, substantial first-pass effect, 50% bioavailability. Metabolized by COP2C9, hydroxylated forms of glucuronidation and sulfation, excreted urine 65%, bile 35%.
What are its main uses and adverse effects, especially regarding that higher liver risk you mentioned?
Uses: long-term RA, OA, AS, pain, primary dysmenorrhea, acute migraine, oral topical gel solution patch, ophthalmic solution. Adverse effects, 20%, HP on GI. Serious GI, hypertension, MI risk similar to COX-2, selective inhibitors. Severe liver injury, higher rate, 611 per 100,000 USUT year. Major monitor transaminases first 8 weeks. Metabolite 4-OA hydroxy diclofenac forms reactive benzoquinoamines, like NAPQI, depletes GSH. U2BT2B7 genetic variation linked to hepatotoxicity, not recommended children, nursing, pregnant women. Indomethacin, potent non-selective COX inhibitor. Used limited by toxicity, safer alternatives, but still used, steroid sparing. Inhibits PMM motility, depresses mucopolysaccharide biosynthesis. Uses moderate severe RAOAAS, acute gouty arthritis, painful shoulder, IV form for patent ductus, arteriosus, closure in premature infants, renal toxicity limits, high toxicity rate, 35-50%, seizures, depression, psychosis reported, caution elderly, epilepsy, psych disorders, Parkinson's, hematopoietic, neutropenia, thrombocytopenia, aplastic anemia. Interacts with diuretics, antihypertensives, blunts effect. Probenecid increases indomethacin levels.
And what about Solandac and ketorolac, often heard in different contexts?
Solandac, prodrug, active sulfide metabolite, is potent COX inhibitor. Uses RA-OAAS, painful shoulder, gout. Lower toxicity than indomethacin, 20% GI, 10% CNS. Etodolac, some QX2 selectivity. Uses post-op analgesia, 6-8 airs, OA, RA, mild, moderate pain, uricosuric, well-tolerated, 5% discontinue. Tolmatin, uses OARA, juvenile RAAS. Food delays, decreases absorption. Side effects, 25-40%. GI, most common, ulceration. CNS, less common, severe than indomethacin. Ketorolac, potent analgesic, moderate anti-inflammatory. Systemic use limited to EVA 5 days, acute pain. Oral IV-IM intranasal. Due to serious GI, renal, bleeding risk, it's be high-dose elderly concomitant NSAIDs, contraindicated obstetrics, severe kidney disease, CABG pain with propionated, topical ophthalmic for conjunctivitis, post-op inflammation. Nabumshan, prodrug for RA, OA, side effects, crampy abdominal pain, diarrhea, rash, headache, etc.
Let's move on to the propionic acid derivatives, including the widely used ibuprofen and naproxen. These are perhaps the most common household NSAIDs.
Non-selective COX inhibitors, common effects, side effects. Some, naproxen may inhibit leukocyte function, broadly approved. Symptomatic RA, juvenile arthritis, OA. Also pain, AS, acute gout, tendinitis, bursitis, headache, dental pain, dysmenorrhea. Efficacy comparable to aspirin for RA-OA. Importantly, ibuprofen and naproxen interfere with aspirin's antiplatelet effect. Generally don't alter pharmacokinetics of oral hypoglycemics or warfarin, but bleeding risk still exists due to antiplatelet effect. Ibuprofen, most used NSAID US, OTCRX, short-acting T12, 2 active. Uses pain fever, OA, RA. Injectable for patent ductus arteriosus. better tolerated than aspirin indomethacin, 5 to 15% GI. Other rashes, thrombocytopenia, avoid third trimester, minimal excretion of breast milk, naproxen, OTCRX, longer, variable T12, 9 to 25 hours, age effects. Uses similar to ibuprofen, FD warning rating, STV side effects, inconclusive evidence, rebelt lower risk, 110% GI adverse effects, CNS side effects, drowsiness, headache, dizziness, vertigo, depression, pruritus, diaphoresis, crosses placenta, appears in breast milk, oxaprozin, unique long T12, 41-55 hours, once daily dosing, slow onset, not for fever or acute pain.
Briefly, what about the phenamates and enolic acids like piroxicam and meloxicam?
Phenamates, mefenamic acid, meclofenamate, and threnolic acids. Typical non-selective COX inhibitors, no therapeutic advantage. Uses: short-term pain, soft tissue, dysmenorrhea, RA, OA. Not recommended children, pregnant women. 5% reversible elevated hepatic transaminases. Diarrhea common, can be severe. Rare autoimmune hemolytic anemia, enolic acids, oxycams, piroxicam, meloxicam. Long T12, once daily dosing. Efficacy similar to aspirin indomethacin, naproxen for long-term RA-OA. Piroxicam. Longest T12, 50 hours, non-selective. May inhibit neutrophil activation independent of COX. Uses RA-OA, acute gout, despite slow onset. 20% side effects, 5% discontinue, maybe more serious skin reactions than others. EMA advises not firstly in acute pain, meloxicam, some COX2 selectivity comparable to celecoxib. Finally, let's revisit the purpose-developed COX2 selective NSAIDs, or COXIBs, which were once hailed as the future. Designed with bulky side chains, fitting COX2 pocket, sparing COX1, promising better GI safety. However, most rovocoxib, valtocoxib, lumiracoxib withdrawn worldwide due to significant cardiovascular complications.
Why the CV problems?
A selective suppression of cardioprotective COX2 PGs, like PGI2, while leaving prothrombotic platelet COX1 TXA2 unrestrained dangerous imbalance.
So is celecoxib the only one still widely available in the U.S.?
Yes, celecoxib is the only purposefully developed COX2 inhibitor still approved. U.S. etoricoxib approved elsewhere, not U.S. None have established superior efficacy to traditional NSAIDs. Should be avoided in patients prone to cardiovascular cerebrovascular disease.
What are celecoxib's key properties and adverse effects that professionals need to be aware of?
Oral bioavailability unknown. Keep 2-4 hours. Elderly may have 2x higher concentrations AUC. Extensively protein bound. Metabolized excreted as metabolites. T12, 11 hours once to twice daily. Increased levels with hepatic impairment. Metabolized by CYP2C9, inhibit CYP2D6, uses acute pain, OA, RA, juvenile RA, AS, primary dysmenorrhea. Dose, OA 200 mg A, RA 100, 200 mg Ibide. Use lowest dose, shortest duration due to CV hazard, adverse effects. Risk, stroke, dose CV, risk dependent. Hypertension, edema, renal PG inhibition. GI advantage loss with aspirin. Chronic use may decrease bone mineral density, older males, slow fracture tendon healing. Etoricoxib. Highly COX2 selective, second only to lumiracoxib. Incompletely absorbed, 80%. T12, 20-26 hours. Extensively metabolized. Hepatic impairment leads to accumulation. Uses: symptomatic OA, RA, acute gouty arthritis, short-term pain, dysmenorrhea, associated with increased risk, heart attack, stroke. Not available U.S.
Wow, we've covered a profound amount of detail on NSAIDs. Now, let's shift our deep dive to the specific pharmacotherapies for gout, a condition driven by urate crystals, which also has fascinating mechanisms.
Gout. Painful, debilitating inflammatory condition. Results from precipitation of urate crystals in tissues, followed by profound inflammatory response. Presence as painful discal monoarthritis, often big toe, can cause joint destruction, tophi, renal calculi, kidney stones, kidney damage. Affects 3% Western adults.
What are the main risk factors for gout that lead to this crystal formation?
Male sex, diuretic use, alcohol intake, obesity, hypertension, consumption of sweetened beverages, red meat, certain seafood, increased purity and low uric acid.
And what's happening at the physiological and immunological level to cause gout? Is hyperuricemia always enough?
Hyperuricemia, elevated blood uric acid, is prerequisite but doesn't always lead to gout. Uric acid is end product purine metabolism, relatively insoluble. Most gout patients. Hyperuricemia from underexcretion by kidneys, not overproduction. Urate crystallizes as monosodium urate in cold or acidic conditions. Peripheral.
Yet the crystals trigger inflammation.
Yes, potent immune response. Monosodium urate crystals activate monocytes macrophages via toll-like receptor, NLRP3, inflammasome activation, secretion of cytokines, IL-1, TNF-I, endothelial activation, neutrophil attraction. Neutrophils secrete inflammatory mediators, lower local pH, more urate precipitation. Vicious cycle.
So the goals of treatment are to break that cycle and manage the urate. What are the main therapeutic strategies?
Exactly. 3 aims: decrease symptoms of acute attack, decreased risk of recurrent attacks, lower serum urate levels. Strategies: drugs relieving inflammation pain, NSAIDs, colchicine, glucocorticoids, drugs preventing inflammatory response to crystals, colchicine, NSAIDs, drugs inhibiting urate formation, allopurinol, febuxostat, or augmenting excretion, uricosurics like probenecid. Also canakinumab, anti-IL-1, approved Europe for refractory gout.
Let's start with colchicine, a truly ancient remedy with an intriguing history.
Colchicine, one of oldest therapies for acute gout, from autumn crocus used since 1500 BCE. Considered second line now due to narrow therapeutic window, high side effects.
How does colchicine, this ancient remedy, actually work at a modern pharmacological level?
Diverse effects. Key: anti-mitotic effect, interferes with microtubule spindle formation, arrests cell division, SP out rapidly turning over cells like neutrophils, GI epithelium, neutrophil inhibition, depolymerizes microtubules, reduces neutrophil recruitment adhesion, decreases chemotactic factor superoxide secretion, inflammasome inhibition, limits MSU crystal-induced NLRP3 activation, less IL-1, IL-18 formation, explains use in familial Mediterranean fever. Other effects: inhibits histamine release, insulin secretion, lowers body temp, enhances sympathomimetics, vasoconstriction, hypertension.
What are its ADME characteristics, especially given its narrow therapeutic window?
Rapid but variable oral absorption, peak 12.52 hours, unaffected by food. 39% protein bound, albumin, large distribution volume, binds tubulin. Significant enterohepatic circulation, metabolized by CYP3A4, some glucuronidation. 40-65% recovered unchanged in urine. High con kidney, liver, spleen, excluded heart, muscle, brain, peak glycoprotein substrate, plasma T12, 31 hour. Contraindicated: hepatic renal impairment plus concomitant CYP3A4 PGP inhibitors. Life-threatening toxicity, not removed by hemodialysis.
And its therapeutic uses for gout, both acute and preventative. How has dosing evolved?
Individualized dosing, age, renal hepatic function, med severity. Acute gout, dramatic relief 20/3 of within 24 hours. Pain, swelling, cribness abate 12 hour, gone 48-72 hours deletion, more or later, much less toxic than old hourly dosing. No repeat courses 2 weeks as hepatic dysfunction dialysis. NSAID leads glucocorticoids preferred if cardiac renal hepatic GI disease. Prevention: recurrent gout, estimated for early anti-hyperuricemic therapy. Dose: 0.6 milligrams 3 to 4 days a week, 1 attack here. 0.6 milligram daily, 1 attack here, up to big board severe attacks.
What about its adverse effects, especially given its narrow therapeutic window and the historical problems with toxicity?
GI toxicity. Most common nearly assigned: nausea, vomiting, diarrhea, abdominal pain, due to intrahepatic circulation GI turnover. Discontinue immediately. Latent period, hours before onset, not dose dependent. Acute intoxication, hemorrhagic gastropathy. Other seriouses: myelosuppression, leukopenia, granulocytopenia, thrombopenia, aplastic anemia, rhabdomyolysis. Rare reversible axonal neuromyopathy. Life-threatening interactions with PGP CYP3A4 inhibitors. Injectable form suspended US 2008. Marketed in combo with probenecid.
Next, let's talk about allopurinol, a cornerstone in inhibiting urate formation. Sounds like a clever decoy, as you put it.
Allopurinol, initially synthesized as antineoplastic, found to inhibit xanthine oxidase, XO, useful for gout. Effective even though under excretion, not overproduction, is main defect in most. Analog of hypoxanthine, active metabolite oxypurinol, aloxanthine is analog of xanthine.
So how do allopurinol and oxypurinol work to lower urate? What's the direct enzyme inhibition mechanism?
Both reduce urate production by inhibiting XO, converts hypoxanthine, xanthine uric acid. Allopurinol, competitive inhibitor low conc, non-competitive high conc. Also, XO substrate product oxypurinol is non-competitive XO inhibitor, responsible for much of activity due to long persistence.
And how does this affect purine excretion? Does it just shift what gets excreted?
Precisely. Without allopurinol, uric acid dominates urine. With allopurinol, urine has hypoxanthine, xanthine, uric acid, reduces plasma uric acid, increases total purine excretion without excessive uric acid load, independent solubilities. Hypoxanthine xanthine efficiently excreted. Small risk xanthine stones if pre-treatment urate very high, minimized with fluid alkalinization.
What are the main clinical benefits of allopurinol beyond just lowering uric acid?
Facilitates dissolution of tophi, prevents delays chronic gouty arthritis progression, lowers uric acid below solubility, prevents uric acid stones nephropathy. Important note: initiating therapy may increase acute gout attacks initially, mobilization of tissue urate. Co-administer colchicine and NSAIDs initially.
Tell us about its pharmacokinetics, how it's absorbed and eliminated.
Rapid oral absorption, peak 60-90 minutes. 20% fecal excretion unabsorbed, 10-30% unchanged urine. Remainder metabolized to oxypurinol. Oxypurinol slowly excreted renally, filtration, some reabsorption. Allopurinol T12, 1 tomar. Oxypurinol T12, 1838 longer in renal impairment, allows once daily dosing. Most common anti-hyperuricemic, distributed total tissue water, except brain, not plasma protein bound. Plasma conc don't correlate well with effects.
What are its main therapeutic uses and dosing guidelines for optimal effect and safety?
Oral BAFE uses. Primary secondary gout, hyperuricemia secondary to malignancies, tumor lysis syndrome, calcium oxalate calculi. Goal, reduce plasma uric acid 6 mg/dL, 5 mg/dL with tophi. Safe to initiate during acute attack if NSAIDs, colchicine given. Dosing. Fluid 2L, slightly alkaline urine preferred. Start 100 ml a day, GFR 40, increase 100 milligram increments weekly. Most maintain 300 ml a day, lower if low GFR. Up to 800 mg a day for hematological malignancy. PEDS, 150, 300 ml a day, secondary hyperuricemia, malignancy. Leishman lowers uric acid complications, not neurobehavioral. Orphan uses. Chagas, kidney preservation.
What about its adverse effects, particularly hypersensitivity reactions, which are a major concern?
Generally well tolerated. Hypersensitivity, most common serious. May manifest months, years later. Pruritic, erythematous, maculopapular rash, rarely urticarial pruritic, rare fatal tinny NSJS, mainly first 2 months. Discontinue allopurinol immediately if any rash develops. Genetic risk factor, HLA, B4, A-beta-1, aspirin, Thai, Sardinian, Italian, Han Chinese. Oxypurinol, available compassionate use if allopurinol intolerant. Other common. Fever, malaise, myalgias, 3% more if renal impair. Rare. Transient leukopenoleukocytosis, eosinophilia, hepatomegaly, elevated transaminases, progressive renal insufficiency, contraindicated, history serious, AD hypersensitivity, nursing mothers, children, except malignancy-inborn errors.
Okay, post-transplant hyperuricemia can use with uricosuric.
And its drug interactions are also complex, correct? Vital to know. Allopurinol increases a probenecid T12 uricosuric effect. Probenecid increases oxypurinol clearance, critically. Inhibits exo inactivation of mercaptopyrinase thioprine, reduce their dose to 25-33%. Increased bone marrow suppression risk with cyclophosphamide, even non-exo agents. May interfere warfarin metabolism, minor PT. Increased rash with ampicillin, causality debated. Hypersensitivity, more common with thiazides plus renal impair. Increased theophylline accumulation toxicity.
Now let's discuss febuxostat, another xanthine oxidase inhibitor, but a non-purine one, making it structurally distinct.
Febuxostat, non-purine exo inhibitor, approved for hyperuricemia in gout patients, alternative to allopurinol. Unlike oxypurinol, forms stable complex with both reduced oxidized exo accession and inhibits function in both states. Rapid absorption, peak 1 to 1.5-ish. Extensively metabolized, UGTs, CYPs. Hepatic renal elimination. Mild, moderate renal hepatic impair doesn't significantly affect kinetics.
How is it used, and what are its notable adverse effects, especially regarding that black box warning?
Approved for hyperuricemic patients with gout attacks, not for asymptomatic hyperuricemia. 40 mg lowers uric acid, similar to 300 mg a day allopurinol, 80 mg a day more effective. Start 40 mg a day. Increase if target not reached in 2 weeks. Common AE liver function abnormalities, nausea, joint pain, rash. Monitor LFTs. Increased gout flares at initiation, urate mobilization, need prophylactic NSAID colchicine.
I recall it also has a black box warning regarding cardiovascular risk, which is significant.
It does. Critical concern. CARES trial showed higher rate misstroke versus allopurinol. Causality debated. Carries boxed warning, possible increased CV death risk. Monitor for CD complications. Strictly contraindicated with mercaptopyrinase thioprine. Increases levels. Does not significantly alter theophylline.
What about uricase enzymes like pegloticase and resburicase? These are very different from the exo inhibitors.
Fundamentally different. Recombinant urate oxidases. Catalyze oxidation of uric acid allantoin. More soluble, inactive, readily excreted. Directly degrades uric acid. Pegloticase. Pegylated uricase. PEG chains prolong T12, reduce immunogenicity. 4-week infusion Q2 weeks. Use severe treatment refractory chronic gout or when others contraindicated. Efficacy hampered by antibody production. 90% loss of effect. Increased infusion reaction anaphylaxis risk. Hemolysis risk. G6PD deficiency. Common AE, vomiting, nausea, chest pain, constipation, diarrhea, skin reactions.
And resburicase, used more in oncology.
Resburicase, racemina uricase, lowers urate more effectively than allopurinol. Use. Initial management, elevated uric acid in pediatric adult leukemia, lymphoma, solid tumors receiving chemo expected to cause tumor lysis, hyperuricemia. Critical and acute cancer care.
limited gout use, activity-limiting antibodies. AE, hemolysis G6PD deficiency, methemoglobinemia, acute renal failure, anaphylaxis, common, vomiting, fever, nausea, headache, abdominal pain, constipation, diarrhea, mucositis. Require special blood sample handling, pre-chilled tubes, ice, to prevent in vitro degradation, spuriously low uric acid values.
Finally, let's explore uricosuric agents, which work by increasing uric acid excretion from the body. These are used when the problem is under excretion. Correct.
Precisely. Typically reserved for patients whose hyperuricemia is primarily due to underexcretion. Need quick dive into renal urate handling. Filtered, secreted, reabsorbed. Reabsorption robust, 10% net excreted. Mediated largely by urate1, SLC22A12 gene, at proximal nephron apical border, exchanges urate for anions, lactate, niconate, chloride.
So how do uricosuric drugs specifically interact with this URAT1 system to increase excretion?
Drugs like probenecid, bisbromurone, losartan compete with urate1 from luminal site, inhibit reabsorption, promote excretion. Conversely, anti-uricosuric metabolites, nicotinate, parasnoid, etc., enhance reabsorption by stimulating urate1. Transport is bidirectional. Secretion involves OAT1, OAT3, MRP4, etc. Drug interactions can inhibit uricosuric agent secretion or urate secretion itself.
Let's focus on probenecid, perhaps the most well-known uricosuric.
Probenecid, highly lipid-soluble benzoic acid derivative. Inhibits organic acid transport across epithelia, primarily inhibits uric acid reabsorption by OATs, principally urate1, uricosuric action blended by salicylates. Also inhibits tubular secretion of drugs. Methotrexate, clofibrin metabolite, via OAT13, increases their plasma levels. Therapeutically exploited to elevate prolonged plasma lactate levels. Penicillin G depresses biliary secretion.
How is probenecid used, and what are its critical side effects?
Completely absorbed orally, peak 2-4 hours. Dose-dependent T12, 5-8M, 85-95% albumin bound. Metabolites retain activity. Oral alone or with colchicine. Start 250 mg BID, increase 500,000 mg BID. Need liberal fluid intake 2L, minimize stone risk. Not for nephrolytic acid and Rolino attacks. Higher doses, 130 adjuvant for penicillin and lactams. Well tolerated, 2% mild GI. Ineffective renal insufficiency, avoid CRCL50. Mild hypersensitivity, 2-4%. Overdose CNS stimulation, convulsions, respiratory failure, death.
What about some of the newer or less common uricosurics, like dotinurad, lesinurad, and benzbromurone?
Dotinurad. Novel urate1 inhibitor, Japan approved, from benzbromurone. Potent urate1 inhibitor, luminal side. 90% absorbed orally, peak 3H. Highly plasma bound, 99%. T12, 10 hour. Glucuronidation, sulfation, main metabolism. Mild, moderate, renal hepatic impaired, doesn't affect elimination. Use. Hyperuricemic gout patients, not asymptomatic. 40 mg, 300 mg allopurinol. 80 mg more effective. Well tolerated, gout flares common initially. Renal calculi, 1.5% suggest potential renal impact, chronic use. Lesinurad. FDA approved combo with XO inhibitor, but discontinued US withdrawn EU. Inhibited urate1, OT4, reduced renal uric acid reabsorption. For gout patients not meeting target with XO inhibitor alone, not asymptomatic monotherapy, black box warning. Acute renal failure, more common mono. Increased creatinine, nephrolithiasis risk, increased mono. Must stop if XO inhibitor stopped. Other AE headache, flu-like, GIARD. Benzbromurone, potent uricosuric, reversible uricamylin tablets. Hepatotoxicity concerns, fulminant hepatitis, limited availability, not approved USEU. Readily absorbed orally, peak 4 out. Metabolized, active metabolites, excreted primarily bile.
Metabolism involves CYP2C9, potent inhibitor, CYP3A4, CYP1A1. Genetic variation affects metabolism. Effective single daily dose, 2,500 milligrams. Effective in renal insufficiency. Prescribed if allergic or refractory to others. Combos with allopurinol more effective. Uricosuric action blunted by aspirin sulfonpyrazone.
Wow. We've journeyed through the intricate and incredibly detailed world of NSAIDs, from their fundamental mechanisms of action on COX enzymes to their diverse roles in managing inflammation, pain, and fever. We've unearthed the fascinating histories of drugs like aspirin and acetaminophen, parsed their complex pharmacokinetics, and critically examined their wide array of therapeutic applications and potential adverse effects.
And then we meticulously explored the specialized pharmacotherapies for gout, shedding light on colchicine, urate-lowering agents like allopurinol and febuxostat, and the various uricosuric agents. We truly went deep, unpacking how these molecules interact at a profound physiological and molecular level with our body's systems.
Our goal today was to provide you, our dedicated listener, with a comprehensive, truly elite professional level of understanding of these crucial medications, going far beyond surface-level information. You now possess a detailed grasp of how these drugs work, why certain side effects occur, the specific molecular interactions, and the delicate balance involved in their clinical use.
This deep dive should empower you to navigate discussions about pain, inflammation, and gout therapies with a newfound confidence and clarity, truly cutting through the information overload you might otherwise encounter.
Indeed. Considering the sheer complexity and interconnectedness of the human body's systems, as revealed by how these drugs interact at such a precise molecular level, it really makes you wonder, what other seemingly simple daily choices might have profound unseen effects on our health, operating beneath the surface in ways we're only beginning to understand?
And how might continuing to unravel these biological intricacies change how we approach wellness and disease prevention in the future, moving us towards even more precise and personalized medicine? Something profound to mull over until our next deep dive.